This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1162, recorded on October 31st, 2024. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone, and
happy
Halloween,
Daniel. Now, your tie is orange. Is that some Halloween thing?
So it's orange, and those that zoom in can see there are black bats on there in tribute to the bat zoonoses that plague us.
Okay.
All right, so let's jump right in, and then a Halloween-appropriate Edgar Allan Poe quotation: "Believe nothing you hear, and only half of what you say." I thought that was very appropriate for the skepticism that we should bring to things as scientists. But just we got a bunch today, so let's hit the ground running, as they say. I think they say that. Mycoplasma pneumonia, an alert from the CDC that we are seeing an increase in cases of what people may know of as walking pneumonia. Mycoplasma pneumonia infections have been increasing, and I'll leave a link into that. People can actually get quite sick from mycoplasma pneumonia. So just I want that on people's radar. The only way you're going to make the diagnosis is if you think about it, if you test for it. Polio, not good news here. North Gaza polio campaign postponed due to violence, says WHO. We read in Reuters, I'll leave in a link, that the polio vaccination campaign in North Gaza has been postponed due to Israeli bombardments, mass displacement, and lack of access. The final phase, due to begin, it's supposed to start Wednesday, the 23rd of October, aimed to vaccinate more than 119,000 children in Palestine. But the current conditions, including ongoing attacks on civilian infrastructure, continue to jeopardize people's safety and movement in northern Gaza, making it impossible for families to safely bring their children for vaccination and healthcare workers to operate, the UN agency said in a statement reiterating its call for a ceasefire. Mpox, we now have the first imported Mpox clade 1b case in the UK. The case was detected in London. Patient was transferred to the Royal Free Hospital's High Consequence Infectious Disease Unit. The UK is now the fifth country to receive an imported case of clade 1b monkeypox. They say case, but that should be clade 1b Mpox, an infection with clade 1b monkeypox virus. Right. And this is added to Sweden, Thailand, Germany, which we mentioned last week, and India.
So last night, Daniel, on the live stream, someone noted this, and they say, should we worry? And I said, you should already be worried for the people in Africa, because we're all in this together. And then someone else said, no one is safe until everyone is safe.
Yes. I appreciate that. Yeah, I mean, we're all in this together, right? The entire world is, less than, a day plane flight away from each other, right? Like we're part of this global community. So hopefully when horrible things happen in the US, like when we had 2,000 deaths a day from COVID, hopefully people didn't just say, oh, should we worry here? Also, and this is going to be good news here in the Mpox arena, Bavarian Nordic, right? I bought some stock there. I don't know if it's doing well, but I feel like I'm part of this. Bavarian Nordic announced Tuesday, October 29th, that the first patients have been vaccinated in a clinical trial to assess the safety and immunogenicity of the Jynneos vaccine in children aged 2 to 11 years old. The trial is expected to enroll 460 participants, mainly in the DRC, but with some sites to be included from Uganda. Really a lot of cases in Uganda, not looking good there. But why am I so excited about this? As we mentioned last week, the deaths, the cases, this is mainly a disease of children. All right. And Marburg, pretty exciting updated Marburg tracking dashboard. sort of just in time, I guess. Last update from the 22nd, we had confirmed cases 62. We now have confirmed cases 66. There's only 2 active cases at the moment, sitting here with 15 deaths so far. But some interesting data. We can now see the male-female gender distribution. You could see cases per age group. Interesting enough, the real peak here is the 30 to 39 group here. So sort of interesting. Folks in their 30s making up 30 of the 66 total cases. Deaths also really mainly in that age group, but a couple deaths in folks under 20. All right, flu. I got an article here. I'll just will comment. So far, not too much flu activity, but we do have the surveillance summary in the MMWR, laboratory confirmed influenza-associated hospitalizations among children and adults, Influenza Hospitalization Surveillance Network, United States 2010 through 2023. So this is a surveillance summary for that block of time. And we get really broad ranges here, right? So seasonal influenza accounts for as low as 9.3, as high as 41 million illnesses. We see a low of 100,000 up to a high of 710,000 hospitalizations per season, and the deaths as low as 4,900, but really getting up to over 50,000 deaths annually in the United States. Now, since 2003, this Influenza Hospitalization Surveillance Network has been conducting population-based surveillance for laboratory-confirmed influenza-associated hospitalizations in the U.S. We end up with weekly rate estimations, descriptions with clinical characteristic outcomes for hospitalized patients. And here we read that during each season, adults aged 65 and over are consistently the highest when it comes to influenza-associated hospitalization rates, followed by children aged 0 to 4, so those little kids under 4. So it's the extremes of age. Among patients hospitalized with influenza, the prevalence of having at least one underlying condition was only 37% among the little kids. So most of those little kids, so over 60% of the little kids, so age 0 to 4, otherwise healthy. Only about a third of them had some underlying condition. Among influenza antiviral use, this increased during the 2010 to 2011 through the 2017-2018 seasons. But then it actually decreased, so it got up above 90%. Now it's dropped down to less than 80%. Now, admission to the ICU, need for mechanical ventilation, and in-hospital deaths, those are going to have ranges, sort of 14 to 20%, 5 to 10%, and then 2 to 3.5%. So just to reiterate that 2 to 3.5%, those are folks that end up in the hospital not surviving, dying from the flu. All right, RSV.
Oh, sorry.
Yeah.
I wanted to say this graph that you put in, right? So we're still pretty flat with flu as of week 36, but so right now this is week 44 that we're in. So there's a little delay in the reporting.
Yeah, there is delay in reporting, which is interesting, right? Because we saw it go up last year about week 46, right?
Exactly.
So we're a little behind on the data. I am hearing from our urgent cares, and I think I mentioned that, I took care of a hospitalized patient with influenza A recently. So we're starting to see a little bit of activity. So, we'll see where we go.
I suspect in the next couple of weeks it's going to go up.
Yeah, we're about that time of year, right? It's been a little bit earlier than prior years, right? So we're just about to, when this drops, it'll be November. We should, about November, December is when we start seeing the upticks historically. Yep. All right. And RSV, I should start right off by mentioning we're starting to see a little bit of activity down there in Florida. But this is very timely. The article, Mucosal nirsevimab levels in respiratory syncytial virus breakthrough bronchiolitis or post-passive immunization disease. This was published in the Lancet Infectious Diseases. So nirsevimab, make sure I add an N to that in my notes, monoclonal antibody with the FC modifications to basically get it to last longer, triple its half-life, targets the prefusion form of the RSV glycoprotein F. Administered intramuscularly. This is that monoclonal that reduces hospitalization, severe forms of RSV in those young kids, lasts for about 6 months after administration. And here, what they're actually measuring is what are the mucosal antibody levels in these kids relative to who ends up getting disease. And actually, it's really interesting. We're seeing about less than half the level of the nirsevimab in the mucosal sites in the folks that end up getting symptomatic disease.
So the ones who have high levels of mucosal antibody, they get other kinds of viruses.
Because this is that test negative study. So they come in, and they've got something going on. So you sort of get this matching. But the ones who actually are coming in with RSV, in general, have less than half, the median levels.
And is that because they're farther out from the infusion?
So that's interesting. I'm not sure I see a great breakdown here. Like, is this a timing issue? Do we need to get the timing better? Is there something different as far as the individuals and them, having something about them that, ends up with them not getting,
study was up to 6 months.
Yep.
Right. Now, I just wonder if these are beyond 6 months, and that's the problem, right?
Yeah, it'd be great to have a nice breakdown and really, because there should be a nice kinetics. Like, okay, so you give it, let's say we check 2 weeks, 4 weeks, 12 weeks, or follow it out would be great. Right. So, because I can't see it realistically. I mean, we had shortages last year being something you give more often, but maybe timing becomes important because as I started to mention, right, we're starting to see activity in Florida, and that's kind of how RSV sweeps up, right? So, do you start off, we give nirsevimab to the little kids in Florida in, I don't know, let's say early October, September, and then we end of October, we do the Northeast and the other parts of the country. So COVID, we're back to COVID, Vincent. It's here to stay, apparently. So the provisional deaths due to COVID-19, no orange there for Halloween, fortunately, nothing but green. So dropping down, there's a few areas where it's in that 2 to 4%. They're the swing states, if you look on the map, right? So we've got Pennsylvania, we've got, Michigan, Wisconsin. Georgia's doing okay, by the way. I just thought it was sort of interesting. But no, in general, we're less than 2% in most of the country. And wastewater is still on its way down. So,
Daniel, why do they have that curve labeled COVID-19, whereas for the others, they got influenza, they have RSV. Why don't they have SARS-CoV-2?
Isn't that so funny? Right. Yeah. So Vincent is talking about this cdc.gov respiratory viruses data activity levels, right? And so, influenza, RSV. I wonder if, because we say, what does this patient have? Oh, they have RSV. Like, I think it might be the virus and disease have the same name. But then they label it respiratory virus. So they should call it respiratory viral syndromes or whatever, because COVID-19, is the syndrome, but the virus is SARS-CoV-2. Yeah.
I mean, CDC should know better, right?
All right. We're going to leave that right out there, Vincent. That's going to be a TikTok. All right. Now, I like to compare this to the UK, which is kind of interesting, right? So they've got that nice influenza pattern, right, where they had their peak last winter, and now you start to see a little bit of an uptick. Their RSV, they're actually really starting to see an uptick over there for RSV in the UK. And COVID just bouncing around. They're actually still pretty high at this point. So, all right, and let's move into to vaccinations. We got a few things to talk about here. So, while we reinforce that vaccines primarily prevent disease and not infection, it would be ideal. We can always ask for this if they could actually do a better job of that bonus, right? Because there is some correlation in the months right after that vaccine or that booster. So Vincent and I can circle back to this. But what we're really talking about here is it's abortive infection, right? And we saw this from the challenge studies, is that you really want everything to kind of stop at that mucosal site. So we're not looking at never getting any viral replication at all. We're talking about an abortive infection where your mucosal surfaces encounter the virus, but you never get sick. So we'll talk about this article here. Repeated COVID-19 mRNA-based vaccination contributes to SARS-CoV-2 neutralizing antibody responses in the mucosa. And this is published in Science Translational Medicine. I'm going to get a counterpoint on this, so everyone kind of get ready for this. So in this investigation, they looked at mucosal neutralizing antibody responses in a cohort of 183 individuals. Participants were sampled at several time points after primary adenovirus vector-based or mRNA-based COVID-19 vaccination and after mRNA-based booster vaccinations. And they report that repeated vaccination with mRNA boosters promoted SARS-CoV-2 neutralizing antibodies in nasal secretions, nasal and serum neutralizing antibody titers of both IgG and IgA isotypes correlated to one another. They investigated the source of these mucosal antibodies in a mouse model. So this is interesting. So here the mice are going to get repeated mRNA vaccines for SARS-CoV-2. And these experiments indicated that the neutralizing antibody-producing cells, I want people to think about, where are those? Are these antibody-producing cells sitting in the mucosa, or maybe they're in the spleen and bone marrow? And actually, what do they find here? That the antibody-producing cells are in the spleen and bone marrow with no proof of tissue homing to the respiratory mucosa, despite this detection of mucosal antibodies, right? So the antibodies are really coming from the serum and then spilling over, right? So serum transfer experiments confirm that circulating antibodies were able to migrate to the respiratory mucosa. And they say that collectively, these results demonstrate that, especially upon repeated vaccination, the currently used COVID-19 mRNA vaccines can elicit mucosal neutralizing antibodies, and that vaccination might also stimulate mucosal immunity induced by previous SARS-CoV-2.
So this is weird because recently there's a paper out of Shane Crotty's group showing if you do nasal swabs, you can actually pick up memory B cells in the nasal mucosa. Yeah. So I don't know there's a difference, obviously, right?
Well, we're going to hit another study, right? So that's this question, right? There's this whole idea that we do have B cells in mucosal surfaces. Actually, the majority of our B cells are in mucosal surfaces in the gut, right? So this is this big thing. And people have been talking about, quote unquote, next generation vaccines. This whole idea that you're going to stimulate those mucosal B cells, because that's really where you want the infection to end. You want it to be an abortive process at a mucosal site. You don't want it to get into the system. You don't want to mount a systemic inflammatory response. You don't want to feel sick. So that was that study. So now here's the next article. It's the same Science Translational Medicine, SARS-CoV-2 XBB.1.5 mRNA booster vaccination elicits limited mucosal immunity. So here the authors point out that yes, current COVID-19 vaccines provide robust protection against severe disease, but minimal protection against acquisition of infection. Intramuscularly administered COVID-19 vaccines induced robust serum neutralized antibodies, but then they say their ability to boost mucosal immune responses remains to be determined. But here we show, in this study, the authors show that the XBB.1.5 mRNA boosters result in increased serum neutralization of multiple SARS-CoV-2 variants in humans, including this JN.1. But in contrast to the other study in the same edition, they found that this mRNA booster did not augment the mucosal neutralizing antibodies or the mucosal IgA responses. So their data is suggesting this separation between peripheral and mucosal immune systems. So what to do? So there's this commentary from blood to mucosa, same edition of Science Translational Medicine, where they try to reconcile this, and they say, well, I don't know, maybe it's different cohorts, maybe the methodology was different, maybe the timing was a little bit different, but yeah, we're not really seeing that we're clear on what's going on here.
Well, we have different. I mean, there clearly are memory B cells and T cells. There are even germinal center B cells in the nasal mucosa, right?
Yep.
That was quite a big study done by Crotty's group. And so if you don't find them, then there's something wrong with your study, right?
Yeah. So interesting, trying to sort this out. But I do see that there's a lot of work going on, because that's really, boy, would that be the holy grail, right? Where you have a vaccine where you really stop the infection right at the mucosal surface without any kind of a systemic response.
Well, I mean, realistically, if you're depending on a memory response, which you would most of the time, it's going to be delayed a few days. So you're always going to get some kind of infection, but it would be dampened, as you say.
Yeah.
And not eliminated. But whether you shed enough to transmit would be a good question. That would be an interesting study to do, right?
Yeah. I mean, that's another really important topic that is, coming back is, how much do vaccines work from a public health perspective, right?
Yep.
I mean, do vaccines, in certain circumstances, we've definitely talked about measles, where vaccines not only protect you and your child, but there's clearly a community difference. So what was the data there where, one person with measles who's unvaccinated will give it to 15 to 20 other people, where a vaccinated person gets infected, it's probably going to take 15 to 20 infected vaccinated people before you get even one case of ongoing transmission. So. All right. So as excited we are about vaccines, we always need to be honest with the fact that there are vaccine-associated adverse events, just so that everyone is aware that we're balanced, we pay attention to that. And here we have the article, Risk for Facial Palsy After COVID-19 Vaccination, South Korea 2021 through 2022, published in Emerging Infectious Diseases. So here the investigators conducted a self-controlled case series to investigate the association between COVID-19 vaccination and facial palsy in South Korea. So they use this large immunization registry that's linked to the National Health Information Database. They include over 44 million patients aged 18 years and older who received at least one dose of a whole bunch of different COVID-19 vaccines. So we've got the Pfizer-BioNTech, we've got the Moderna, we've got the Chadox, we've got the J&J in there. And they're looking at people that had a facial paralysis diagnosis, and then they're going to compare the facial paralysis incidence in a risk window, that really first 28 days after vaccination, compared to a control, which is really a remainder. They found that 5,211 patients experienced facial paralysis within the risk window. And then this is compared to over 10,000 within the control window. And they did actually find that there was an increase in facial paralysis within the 28 days post-vaccination, primarily after first and second doses. But now there's a couple comments, and I think this is really interesting. So first, this is not something seen in isolation. They didn't just pull this out. So they actually point out that there's been this noted positive association with vaccination in some other studies. They mentioned the study that was done in Israel, and that was a Pfizer association. There was another analysis in the UK. There's one that's out of Hong Kong, China. Now, here's where it gets complicated, right? So people say, oh my gosh, I don't want to get that vaccine. I might get facial paralysis. But what about the risk of facial paralysis if you get COVID-19 infection and you don't have the protection of a vaccine? So here in South Korea, they look through this, and the annual incidence of Bell's palsy had increased from 23 cases pre-pandemic to 32.5 cases per 100,000 during the first couple of years, so 2021, 2022. Now, a retrospective cohort study in South Korea indicated that COVID-19 infection itself is actually associated with a higher risk for Bell's palsy. And then you can look at people who are vaccinated. There's about a 1.2 risk. But if you're unvaccinated, it's 1.84. So a 60% higher incidence if you don't have the protection of the vaccine. They do a little bit of sort of hand-waving thought experiment, thinking about what might be going on here. Why is this potentially happening? They're thinking, could the lipid nanoparticles used to encapsulate the spike antigen or the inflammation triggered by the mRNA or the viral vector be stimulating production of type 1 interferons and interferon-stimulated genes? Maybe this is resulting in a targeting by the immune system of the myelin basic proteins, and then maybe this is damaging the myelin sheath. And this is actually sort of parallel to what we've seen when we used to use interferon therapy for certain folks and then induce Bell's palsy with that.
So Daniel, what is facial palsy?
So you've got the facial nerve that comes out. I sort of use my hand because it's got multiple branches that come out. Uh-huh. And so it's motor function, and the motor function gets disturbed. So you see a droop. You see a one-sided facial droop.
Is this permanent?
So it depends. In most cases, it's not. In most cases, it resolves.
Right. So I don't understand these results at all. So
okay,
days 1 to 28 after vaccination, you get 5,000 cases. So what if you didn't vaccinate anyone? What would you get? Would you get 5,000? What's the baseline?
Yeah, the way they do this actually is a little bit, because they're looking at this sort of period of time, so it's relative to period of time. So one is the way I would have loved if they did this the way they did like cases per 100,000 persons, right? So that if they had broken it down and say, okay, so we got 28 days, so we're seeing 5,000 cases in those 28 days, and then we could use this denominator of 44 million, and then have the others say, okay, now we're looking at this 240-day observation period, but you got to break that down, right? You got to divide that by 10, get it close to, or 9, and then break it. So I was a little troubled that I didn't get kind of the best breakdown of the raw data to really, ask. Because the other side is, what if you don't vaccinate? You just let everyone get COVID without the protection. I mean, ultimately, you end up with more Bell's palsy, more facial paralysis.
Yeah, I just think maybe there's a baseline rate of facial palsy, right?
Yeah.
And maybe it's 5,000 per 44 million. I don't know.
Yeah. So it's really hard because I think at the end of the day, I come away with this like, okay, yeah, you may see some temporary facial paralysis from the vaccine, but you're going to get a net protection by reducing the facial palsy you get from not being protected by the vaccine.
And they looked at both mRNA and adenovirus vaccines. Yeah.
Yeah. They're looking at. Yeah.
So that's unusual. It must have something to do with the antigen, I would guess, not the vector itself.
Yeah, when you looked at the raw data, it was actually a little higher in the viral vector than it was in the mRNA, right? Not what most people probably thought going into this.
Yeah.
And passive vaccination is a little bit update. I was just talking to my one of my partners, Marilyn Fabry, today. At least in our local area, there's a company, Prime Infusion. So primeinfusions.com/locations. Like half a dozen locations in our immediate area. It's helping us get this passive vaccination to our patients. All right. Early viral phase. We have our treatment guidelines. We keep putting them out there. And we have an article. And this is, I think, an important one. I wasn't sure. Should I put it here? Should I put it in the long COVID section? Maybe I'll just discuss it twice. No, I won't. But number one, what do we recommend Paxlovid? And we recommend Paxlovid based upon the data that it's going to prevent hospitalization, death, severe disease. But here we have the article, nirmatrelvir plus ritonavir reduces COVID-19 hospitalization and prevents long COVID in adult outpatients, published in Scientific Reports. And we've talked about the fact that only 5 to 6% of studies look at long COVID. And we really need to look at that because for most of us, most of our patients, no one thinks they're going to end up in the hospital. Nobody thinks they're going to die, but they are starting to learn about long COVID, and they do not want that. So this is a retrospective cohort study where they're going to look at nirmatrelvir, ritonavir, Paxlovid in preventing severe disease, progression, and long COVID. And treatment was associated with, as I think reiterating, a notable reduction in COVID-19 related hospitalizations, so a 61% reduction. And we're seeing that the Paxlovid was associated with fewer long COVID symptoms, so almost a 60% reduction. Yes.
I mean, they say prevents long COVID in the title. That doesn't prevent, it reduces it, right?
It's associated with fewer long COVID symptoms.
Yeah. I don't think prevent is the correct word, right?
Yeah, well, I think this is one of the challenges, right? So a lot of docs say like, oh, there was that study. So we've got EPIC high risk, right? And then we had EPIC SR. So the primary outcome in SR was, basically 0 symptoms, right? So you make it a binary. And as a binary, it fails. But if you look at the issue, so does it reduce the symptom severity? Basically, yeah, Paxlovid makes you feel better acutely. And here we're seeing, about a 60% reduction in the number of long COVID symptoms. So if you do it as a binary, a little bit of an issue because like people are, I want to be 100%. Well, I can, reduce your symptoms by 60%. But yeah, the binary is really the challenge. All right. Now, this is another one of the things we've tried that didn't quite work. And so this is the article, Time to Sustain Recovery Among Outpatients with COVID-19 Receiving Montelukast, that's singular versus placebo. And this was published in JAMA Network Open. So this is the ACTIV-6 randomized clinical trial data. And so this is the ACTIV-6 conducted January 27 through June 23, 2023. Omicron circulating, participants age 30 and older. And there's going to be a 1-to-1. You're going to get the singular or you're going to get placebo for 14 days. And here the primary outcome was time to sustained recovery. So 3 greater than or equal to 3 consecutive days with 0 symptoms. So we're going to do a binary here. Really what we end up seeing is randomized control clinical trial. Treatment really didn't succeed in doing anything. So they don't really support using a singular for the treatment of acute COVID. Things are still the same with the early inflammatory week. So steroids, anticoagulation, pulmonary support, remdesivir, immune modulation. And just one, we're going to round it out here with one article about long COVID. So what about long COVID? Now, I was thinking about how we get emails with people surprised that physicians are saying that the current or the new COVID is just a cold versus that old COVID that was really bad and required treatment. And so maybe the right question is, what about long COVID? So we have the article, Clinical and Functional Assessment of SARS-CoV-2 Sequelae Among Young Marines, a panel study published in the Lancet Regional Health Americas. So these investigators, this is sort of a personal connection here, they used a cohort of U.S. Marines from a previous longitudinal prospective observational study of acute SARS-CoV-2, most of whom were enrolled prior to the infection. A panel study was established to assess for post-acute sequelae of COVID-19, so PASC, and they're defining it as symptoms at least 4 weeks, right? So 4 weeks, we've talked about 8 and 12, so this is almost a medium-long COVID definition. So symptoms at least 4 weeks after symptom onset or diagnosis, and they're going to assess these with questionnaires, this validated quality of health metric. They're even going to do fitness testing, which I really liked here. And they're going to compare this. So they're going to look at globally dispersed Marine participants, right? So these are like these young, healthy, robust folks. They're predominantly male, so 91.7%. So not all male. So an N of 825, mostly male. Median age of 18, so really 18, 19, they're young folks. Among these participants, a quarter of them developed PASC. A quarter of these young, healthy folks had symptoms past 4 weeks. And what were the symptoms? And this matters, right? So the most prevalent symptoms were loss of taste and smell, right? And I don't think a lot of us are, sympathetic to that. They're like, all right, so you can't taste and smell, you young Marines. That's 40%. But almost 40% were having shortness of breath, trouble breathing. 23% were having cough. They also were having higher issues of somatic and general depressive symptoms, issues with anxiety. And here, this is really interesting. So compared to an historic cohort of Marines, the folks with PASC, they actually scored worse on their physical fitness assessments due to slower run times. And those who ended up with PASC continued to have decreased physical performance 1 year after completing their initial training. So I sort of thought about this, right? I was talking to my wife Jessica about this, and I was telling I don't know if you know this joke about there's two guys and they're up in the Alaskan wilderness, and they come over this rise and they see a grizzly. The grizzly sees them. The grizzly starts charging at them, and the one guy bends over and he starts like double tying his shoelaces, and his friend's like, "Dude, I don't see what you're doing. There's no way you can outrun that grizzly." And he says to his friend, goes, "I don't need to outrun the grizzly. I just need to outrun you." Right? Right? And so like, oh, what's the big deal? These Marines are just, they're slower than everyone else. Well, they're slower than the rest of the battalion, right? So they're in this bad situation and, and they're like, all right, retreat or run or wherever they got to go. And you got a quarter of them with PASC who just can't keep up with the group. That's not okay.
That's a very good cohort to do this in. It's very clear, right? Compared to the general population where it may be a little fuzzy.
Yeah.
Right.
Yeah, because we measure them. We not only do you feel, but then we make them run and we measure their, run times and they're not keeping up.
Nope.
Yeah.
I got a joke for you from last night's live stream. This is really good.
Okay.
So this guy said, "I never get sick on the weekends. I only get sick during the week, Saturday and Sunday. I never get ill. I must have a weekend immune system."
Oh, I love that. I'm going to use that.
You should use it.
Yeah.
Weekend.
All right. Well, that's going to wrap us up. And as we've been saying for a long time, no one is safe until everyone is safe. Now, Vincent, this is going to get you excited because when this drops, it's going to be November. And November, December, and January is our Microbe.tv fundraiser. So
right.
Thumbs up. It's the year end, right? This is when people like to donate. I'm very confident that we're going to get up to that donation of $20,000. We are going to double your donations to get up to that maximum donation of $20,000. So, and I gave you two choices. Come here to parasiteswithoutborders.com, click donate. We're going to double your money for the next 3 months. But you can even go right to microbe.tv and give them your money directly without the doubling. I think the decision's
it's up
easy.
To you. Make your money go longer.
All right. And just remember, no one is safe until everyone is safe, as some of our live stream listeners pointed out last night.
As you know, we here at Microbe TV, we depend on your donations to fund our activities. And we don't do ads. We don't have that sort of income. So if you like this kind of science reporting, please help us out. Go to parasiteswithoutborders.com and they'll double your donation. It's time for your questions for Daniel. You can send them to daniel@microbe.tv. Rach writes, "I had an accident and both knees have been damaged. I was given a cortisone steroid injection in the right knee in August and one in my left knee 2 weeks ago. I can now walk without crutches, but I am concerned it may lower my immunity to SARS-CoV-2 or flu infections, etc. I'm not sure to what extent this could be a problem." So she goes ahead and tells us about all her immunizations and what you can and can't do. But last night she was on the live stream and I told her to ask you, would these steroid infections in the knee be a problem?
Yeah. So, I mean, the steroid injections, these are depot, so a delayed action. So yeah, you're technically on steroids, right? So when someone was going to assess your risk, they'd say, okay, you may be 63, but you're immunocompromised, right? To some degree, your immune system is not where we would like it to be. I'm not sure why you can't get access to Paxlovid where you are, right? I guess you're Isle of Man. So what are the things gonna be? So we've talked a little about. So one is, you have got, 2, 3, you've gotten, multiple vaccine doses. You've had COVID a couple times in the past. The extra boosters, they're gonna sort of add on top of that, but you already have, a protection against severe disease. So, and that's probably a persistent 90% reduction. A lot is probably driven by T cells. So we're okay there. The other is, remember, that Paxlovid is going to reduce your risk from where it is right now. And at 63 in your context, your risk is already reduced. So yeah, I would love, if there was a situation that you could reduce that even further with Paxlovid. But yeah, that sort of wraps it all up for you. So it is that time of year. Try to be safe. Isle of Man, you're over where we're seeing a little bit of COVID activity at the moment.
Yeah, she always says on the stream that you can't get Paxlovid on the Isle of Man, which is between England, the UK, and Ireland, right?
Yeah.
I told you that you could do molnupiravir or remdesivir, right? Those are options.
Yeah, if there's access. I mean, the reduction that we saw in the Pine Tree study with remdesivir was about 90%. So that's an option. Molnupiravir, we say about 30% combined endpoint, but if you looked at mortality, it was actually even better than that. So no, you do have some other options out there.
Okay, Amy has 2 questions. 1, 'tis the season to gather. Before COVID, my family would celebrate Thanksgiving with their dear friends. Wasn't a huge gathering, about 13 people. I've declined the invite since 2020 because I want to avoid getting exposed. I did get COVID summer 2023, just now recovering from debilitating fatigue. My friend who is hosting Thanksgiving offered to have everyone test the day before we gather. I understand the antigen tests do a decent job detecting virus if one is symptomatic, but not great if they're not. Obviously, if someone tests positive, it's a done deal. But how much peace of mind should 13 negative antigen tests give me?
Yeah, let's start with that because we've got a couple of questions here. So, probably the ideal way to do this, right? Because it sounds like you really suffered pretty miserably from long COVID for a long period of time. The last thing you want to do is have that again, reset the clock on that. As mentioned, the tests are most sensitive in someone who's symptomatic, right? That's been consistent. It's really not, variant specific. It's symptom. The other is that probably ideal is to do tests the morning, right? That morning of the event of Thanksgiving gathering. And you can get these Lucira molecular nucleic acid amplification tests, which have a better sensitivity than the antigen. So, you could just do antigen tests across the board. If you're going to do that the morning of, not the day before. And if you're going to do molecular tests, which do cost a little bit more, but have a better sensitivity, again, the timing would be, the morning before the gathering.
All right. Number 2, my dad recently developed shingles, even though he was fully vaccinated. He says he read somewhere that the COVID vaccines can trigger the dormant shingles virus to wake up and wreak havoc. Is there any evidence of this? My dad was vaccinated for COVID a few weeks before he developed shingles, and vaccinated for shingles a few years ago.
Yes, so there is an increase in shingles. So in the varicella zoster, the chickenpox virus coming out of latency with acute COVID. There even is a little bit of an association post-vaccination. So when people are, people were back making these decisions, a lot of times say, get that shingle shot, get those 2 shots, get those COVID vaccinations. But and I think the other, just Shingrix. Like if you're 50 and over, about 1 in 3 people are going to end up at some point getting shingles. And of those people that get shingles, about 20%, so about 1 in 5 are going to get that post shingles neuralgia, so that ongoing burning pain. So really, everyone get those shingles shots.
Philip writes, I appreciate your comments about the respiratory diseases in England and your comments about the tube. My wife and I were in the UK and Ireland from October 2nd till the 22nd. We caught something while in London. We did use a lot of public transport. We've all had RSV vaccines. We updated COVID and flu vaccines just at the right time before the trip. As to pertussis, I understand at 1 year, protection is 70%. At 4 years, it drops 30 to 40%. With the drop in the vaccinated rate in general and the lowering of herd immunity, is 10 years too long for Tdap boosters?
Yes, this is an excellent question, right? So, I sort of talked about this a little bit previously. So, quadruple the number of cases of pertussis here. And actually recently reviewed a poor individual who actually died from pertussis. Ended up in the hospital, ended up bacteremic, right? Occam was not a doctor. You could have that second thing going on. And a lot of times that's what drives the hospitalization, and what are, sort of looking through the recommendations for this tetanus, diphtheria, acellular pertussis kind of all in one. And the recommendations really seem to be driven by tetanus kind of every 10 years. But when you start looking at the quadrupling, you start, going through data, the protection dropping as quickly as you're describing. Yeah, it does really make us need to rethink, like, is every 10 years, a little too long, actually, when you're dropping down to these lower rates.
Lisa writes, I was wondering if protecting the eyes against COVID droplets, like wearing bigger glasses or wind-protecting biking glasses, are useful to prevent COVID infections, obviously in addition to wearing a good mask. In the beginning of the pandemic, medical personnel were using face shields to protect the mucosa in their eyes. Are there any data studies on this subject? If not, do you think it's a reasonable measure in any way? And this practice has just been abandoned in the hospitals for practical reasons. I have to buy new glasses anyway, and would choose bigger ones if it would help me avoid an infection.
So, yeah, I remember, the kind of the history on this, which was, early on, there was a study where they looked at people that wear glasses and people that don't wear glasses, right? And there was people wearing glasses had a lower incidence. And we sort of discussed, was it the glasses or glasses a marker of intelligence, right? You could see that Vincent's the one wearing glasses between the two of us. I put mine on periodically. And actually there was in the quote unquote droplet protection, we would end up in the hospital if we were seeing someone who then tested positive, and we were wearing an N95 and goggles. That was really what, allowed us to keep working. So, there's a little bit of controversy, but in general, right, the vast majority of the way that you get COVID-19 is by breathing in the virus. So, hey, if you're going to buy some new glasses anyway, and you're going to choose some bigger ones, and they're going to work well with the aesthetic of your face, I think that's reasonable.
And Charmaine writes, I was a bit confused listening to your conversation about losartan. I get it that it's not to be used as a COVID treatment, but was rather alarmed at the worse outcomes. I have a friend who was just put on losartan for hypertension. I've been on olmesartan for decades. Should we not be taking ARBs for our BP and be on a different type of BP lowering drug? I certainly don't want a worse outcome because of that, even though, of course, I've been doing and would continue doing everything else right as far as vaccines and treatment.
Yeah, so Charmaine, this is a good question. I was thinking about this weekend, and I actually got asked very much the same question. So I'm sailing. It's the last weekend sail of the season, doing this 100-mile trip with my cousin Peter Dates, and he's on the same class of medicine. Sharing his confidential medical stuff here. You want to know, like, what's the story? Like, is it okay? I'm on this, and I really think I will sum it down and say, it is not good for treatment. And actually, what were some of the worst outcomes? You're taking people and you're putting them on a medicine that decreases their blood pressure, really at a time when that can be kind of an issue for us. So I don't really think a takeaway from the study was that people who are on this medicine for their hypertension need to be more concerned. I don't think the papers suggest that those people are at higher risk. But what it does say is it's not a great time to be starting an ARB.
That's TWiV, Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone, be safe.